Before we get started, I just want to review the thyroid hormone negative feedback loop, which a lot of us probably haven't seen since anatomy and physiology. In this feedback loop, the hypothalamus and the anterior pituitary gland work together, where thyroid-releasing hormone comes from the hypothalamus to stimulate thyroid-stimulating hormone from the pituitary gland. The TSH travels through the bloodstream, connects up with the thyroid gland, and stimulates the thyroid gland to produce thyroid hormone. Thyroid hormone comes in two forms, T3 and T4. T4 is the inactive form and T3 is the active form. Those travel throughout the body to stimulate growth and metabolism. And they also travel back to the anterior pituitary and to the hypothalamus. And this is the negative feedback portion of the system. When they present to the hypothalamus and the pituitary gland, those glands stop releasing TRH and TSH. So now that we've reviewed that, let's define hypothyroidism. So hypothyroidism is low or no production of thyroid hormone by the thyroid gland. And thyroid hormone, we saw, is important because it's required by all cells for normal growth and metabolic activity. So what causes hypothyroidism? In the United States, 99% of cases are from Hashimoto's thyroiditis, which we'll talk a little bit more about in a second. Other possible causes for hypothyroidism are surgical resection, so potentially after thyroid cancer. Iodine deficiency is very common in other countries where iodine is not as easy to get in the diet. There are also congenital defects that can cause hypothyroidism and also secondary hypothyroidism where there's potentially a problem with the hypothalamus or with the pituitary gland and they're not producing TRH or TSH. So let's talk about Hashimoto's real quick, since that's the most common thing we'll see here in the United States. It's an autoimmune disease where the body is producing antibodies for some reason that are attacking the thyroid gland. So we'll see when that thyroid gland is being attacked, it's not producing T4 and T3, and we're not getting that negative feedback loop. So here we can see the antibodies attaching to the thyroid gland, and that thyroid gland is pretty unhappy. And because it is being attacked, it's not producing very much thyroid hormone, perhaps just a trickle. And the lack of thyroid hormone in the body is going to cause a wide variety of symptoms. And also notice that there is no circulating thyroid hormone to go back up to the pituitary and the hypothalamus and tell them to stop secreting TRH and TSH. So now that we've reviewed hypothyroidism, let's meet our friend Lulu B. Lethargic. She'll be our case study for today. Lulu's a 29-year-old female. She's experiencing fatigue, cold sensitivity, constipation, weight gain, edema, weakness, thinning hair, depression, and irregular menses. So as we're trying to diagnose hypothyroidism, let's remember that there are a lot of possible causes of fatigue. Lulu could be anemic. She could have an infection. Perhaps she has heart failure or cancer, or maybe she's just in nursing school. So when she goes to see her primary care provider, they're going to need to rule out those possibilities versus hypothyroidism. And they're going to do that with a variety of labs and diagnostics. So when she sees her doctor, they'll likely order a CBC and a CMP, but also thyroid-specific labs. And we'll talk more about those in a second. If the primary care provider palpates any nodules on her thyroid, then they may use a thyroid ultrasound or other labs and diagnostics as necessary. So these are the thyroid-specific labs that we were talking about. You'll see the normal values here for TSH, T4, and free T4. When the primary care provider runs those labs, they may end up running thyroid antibody labs as well in order to differentiate between different causes of hypothyroidism. So when we revisit Lulu B's labs, we'll see that her CBC came back within normal limits. Her CMP is within normal limits. But when we look at those thyroid labs, we'll see that that TSH is really high and that free T4 is really low. So when the doctor sees these labs, he'll probably order those antibody labs too, and we'll see that those antibody labs both came back high. So because of that, we can diagnose her. We can review this negative feedback system and remember that that is why her TSH is high and her T4 and T3 are low, because she's lost that negative feedback system. And that points us over to Hashimoto's thyroiditis. And we're going to treat that with a drug called Synthroid. So let's talk a little bit more about Synthroid. Synthroid is levothyroxine, and it is a synthetic T4, which is that thyroid hormone that we've already talked about. The mechanism of action of this drug is that it provides exogenous thyroid hormone as the inactive form, T4. So it requires your body to convert that T4 into the active form of thyroid hormone, which is T3. And then that T3 is able to stimulate your cells through growth and metabolism. When your primary care provider is dosing Synthroid, they'll generally start pretty conservatively. And you'll go back to the doctor multiple times to have your labs rechecked and potentially calibrate that medication again. And as you are on this medication, they want to see your free T4 levels rising back up to normal and your TSH levels falling back to normal, because now you're regaining that negative feedback loop. Some of the adverse effects of this medication can be hyperthyroidism, because if we give you too much of this medication, now we're sending you over to the other side of the cycle. And it needs to be used with caution in elderly patients and those with heart disease, because it can cause an increased risk for angina, arrhythmia, MI, and cardiomyopathy. Why is that? Because thyroid hormone increases the myocardial oxygen demand. So it's very important that we start with low doses and monitor these patients until we figure out what exactly they need. Some of the important nursing implications on this medication are that the patient needs to take it on a completely empty stomach. And often we do this by encouraging patients to take it first thing when they wake up in the morning, so even before they have a cup of coffee or any breakfast. And we're going to have to teach this patient about the signs of hyperthyroidism, and we're going to have to teach them about possible heart conditions and that they need to report any complications that they're having immediately. There are a few other treatments that can possibly be used for hypothyroidism as well. One is desiccated thyroid, which is known as Nature-Throid or West-Throid, and this is actually a thyroid hormone that's derived from pigs. So it comes as a more natural form because you have that ratio of T4 and T3 that you're ingesting at the same time. So some patients do better on a medication like this. There's also a drug called Cytomel, which is a synthetic form of the T3 hormone, which you'll remember is the active form of that thyroid hormone. It is given in extremely small doses, and it's really hard to get a steady state because it's very easy to get toxic with this medication. So it needs to be used with great caution. And finally, it's really important to treat any nutritional deficiencies that this patient may have. The main one that you would see worldwide would be iodine, which is required for thyroid hormone synthesis. And patients with iodine deficiency often develop a goiter, which we can see here. And you're not often going to see this in the United States because we added iodine to our salt supply many years ago, and there's hardly any Americans that are having a hard time getting enough iodine in their diet. Selenium is also important for the conversion, and selenium deficiency will exacerbate Hashimoto's. So now that we've talked about this treatment therapy, Lulu's been on this therapy for a few weeks, and she's going back to see her primary care provider. So let's go check in and see how she's feeling. Looks like Lulu's gotten her energy back.